Viewer discretion is advised. Some slides may have visual effects that aren't always suitable for all audiences. We use the Emergency Medical Responder book First on Scene for the Emergency Medical Responder course. We do not get paid to use this book, however, over the years, this course has been the easiest for our students to comprehend, therefore is why we utilize it. This work is protected by the United States copyright laws and is provided solely for the use of our instructors to teach courses and assess the students' learning process. The content on this website has been made available for our instructors to copy and distribute to students in our classes as we see necessary. All education provided is a guideline to help you learn new concepts to better treat your patients. Your local protocol supersedes any education you learned in this course. You must always review with your medical director before changing your treatment plans that are outside your local protocols. The objectives that we're going to talk about are identifying the anatomy of the respiratory system and describe the basic respiratory physiology. We're also going to define the following terms: abdominal thrusts, accessory muscles, agonal respirations, apnea, and bag mask device. Biological death, cardiac arrest, chest thrust, clinical death, cyanosis, diaphragm, dyspnea, epiglottitis. Exhalation, gag reflex, gastric distension, head tilt chin lift maneuver, hypoxia, inhalation, inspiration, jaw thrust maneuver. Laryngectomy, larynx, nasopharyngeal airway, oral pharyngeal airway, patent airway, pharynx, pocket face mask, and positive pressure ventilation. Pulmonary resuscitation, rescue breathing, respiration, respiratory arrest, respiratory compromise, and respiratory distress. Stoma, tidal volume, trachea, tracheostomy, and ventilation. State the oxygen concentration of room air, describe the common causes of respiratory compromise, differentiate between clinical and biological death, describe the signs of a patent airway, and describe the signs and symptoms of adequate and inadequate breathing. Explain the benefits, indications, and contraindications of positive pressure ventilation. Describe the management of a patient's airway when there is a suspected spinal injury. Explain the appropriate steps for rescue breathing with a barrier device. Differentiate the signs of adequate versus inadequate ventilations. Differentiate the airway management of pediatric, adult, and geriatric patients. And describe the common causes of airway obstruction. Differentiate between anatomical and mechanical airway obstruction. Differentiate the signs and symptoms of a partial and complete airway obstruction, and describe the care for a patient with a partial and complete airway obstruction for the adult, child, and infant. Explain the indication and contraindications for the insertion of an oropharyngeal airway. Explain the indications and contraindications for the insertion of a nasopharyngeal airway. And explain the indications for oral and nasal suctioning. Differentiate between manual, electric, and oxygen-powered suction devices. Demonstrate the proper technique for the head tilt chin lift maneuver, and demonstrate the proper technique for the jaw thrust maneuver with or without a pocket mask. Demonstrate the proper technique for the insertion of an oropharyngeal airway or an OPA. Demonstrate the proper technique for the insertion of a nasopharyngeal airway, also known as an NPA. And demonstrate the proper technique for oral suctioning using battery-powered and hand-operated suction devices. Demonstrate the power technique for nasal suctioning using both a battery-powered and a hand-operated suction device. Demonstrate the proper technique for the use of a bag valve mask device on the adult, child, and infant. Demonstrate the proper technique for providing positive pressure ventilation for a patient with inadequate respirations for the adult, child, and infant. And demonstrate the proper technique for caring for a foreign body airway obstruction in the adult, child, and infant. Value the priority of an airway management in the overall assessment and the care of the patient. Explain the rationale for using a barrier device when ventilating a patient. In this section, we're going to talk about breathing and ventilation. Breathing and ventilation. So the air that we breathe is comprised of a mixture of gases, which is made up of approximately 78% nitrogen and 21% oxygen. The act of breathing is commonly referred to by the medical professionals as ventilation or respiration. Ventilation is the process whereby air and oxygen are brought into the body. The body's cells, tissues, and organs need oxygen for life, and all life requires energy. The body uses that oxygen to produce the energy needed to contract the muscles and send nerve impulses, digest food, and build new tissues. So in addition, the ventilation process allows for that removal of carbon dioxide, which is the waste byproduct of the cells. The term respiration is also used to describe the process that involves the exchange of oxygen and carbon dioxide within the cells, which is then called cellular respiration. So the normal limit for ventilations is between 10 and 29 for an adult, 18 to 34 for children between the ages of 4 and 12, and between 30 and 60 for the infant or younger than 1 year of age. So this process of breathing maintains a constant exchange of the carbon dioxide and oxygen. So if your breathing is not adequate, or if it stops, cells can then become starved for oxygen, which is known as hypoxia. If the breathing remains inadequate for too long, carbon dioxide may accumulate in the body's cells and become a very deadly poisoning. So a patient who is not breathing adequately is said to be experiencing respiratory compromise, which is an early sign of respiratory compromise is respiratory distress. So respiratory distress is usually pretty obvious because the patient's work of breathing then increases. If the adequate breathing is not restored quickly, the patient may progress to a condition known as respiratory failure. So respiratory failure is characterized by the presence of an altered mental status. If the respiratory distress is not adequately addressed, the patient will stop breathing altogether, which then becomes a very dangerous condition known as respiratory arrest. So some causes of respiratory compromise can be asthma, bronchitis, heart attack, severe allergic reactions, exposure to toxic substance, and inhalation of superheated air. Hypoxia is the insufficient level of oxygen in the blood and tissues, whereas respiratory arrest, remember, is the absence of breathing or that apneic stage. So the absence of breathing is called apnea. Once apnea sets in, the heart will soon stop as well. This is known as that cardiac arrest. The heart requires a continuous supply of oxygen to function. The moment that both the heartbeat and the ventilation stop, a condition called clinical death occurs. 4 to 6 minutes after clinical death, oxygen is then depleted and the cells begin to die. This is the time period when it is most critical for the patient to receive that CPR. If the patient's cells do not receive the oxygen within 10 minutes, irreversible death may occur. The organ affected first is the most critical one, which is the brain. And then biological death occurs when too many brain cells die, and then clinical death at that point can be reversed, but biological death cannot. So again, remember that without oxygen, brain cells begin to die within 4 to 6 minutes, and it's an irreversible death that may occur in as little as 10 minutes. So how do we breathe? Under normal circumstances, breathing is a process that occurs automatically and without any effort. Even though you can temporarily control the rate and the depth of your breathing, that control is short-term and is soon taken over by the involuntary orders of the respiratory center of the brain located in the medulla and the pons. So if you try to hold your breath, these centers will first urge you to breathe and then take over and force you to breathe. If you try to breathe slow or shallow breaths while running, those brain centers will automatically adjust the rate and the depth of the breathing to suit the need of your body. The needs of your cells, not your will, are the determining factor in the control of your breathing. So the volume of the chest cavity is increased by the muscle contraction. This may sound backwards because contractions usually make things smaller. However, as the muscles between the ribs contract, they actually pull the front of the ribs up and out. So the primary muscle of breathing is the diaphragm. When the diaphragm muscles contract, it moves downward, and both actions result in an increase in the size and the volume of that chest cavity. So with each inhalation or breath taken, the size of the chest cavity then increases, causing a decrease in the pressure within the lungs. When this occurs, the lungs then expand automatically. As the lungs expand, the volume inside each lung then increases. This means that the pressure inside the lung will decrease. As you may know, air moves from high pressure to low pressure. So when the pressure inside the lungs becomes less than the pressure in the atmosphere, the air rushes into the lungs. It moves from the high pressure to low pressure, and then it will continue to do so until the pressure in the lungs equals the pressure in that atmosphere. So for exhaling or breathing out, the process is reversed. That's when the diaphragm muscle and the muscles between the ribs relax, which then makes the chest cavity smaller. And as the chest cavity gets smaller, the pressure then builds up in the lungs until it becomes greater than the pressure in the atmosphere, and then we must do an exhale. And that's when the air flows from a high pressure with the full lungs to a low pressure, which is at that atmosphere. Remember, the diaphragm contracts and moves downward on inspiration and relaxes and moves back on exhalation. In this next section, we're going to talk about the respiratory system anatomy. So with the respiratory system, there are several important parts of the respiratory system that have already been discussed. However, the respiratory centers in the brain and the muscles of the respiration, including the diaphragm and those between the ribs. So other major structures of the respiratory system include the upper and lower airways. So first we'll talk about the nose. So the nose is the primary path for air that enters and leaves the system. As the air enters, the nose filters it and it helps to moisten it. Next is the mouth. The mouth is the secondary path for the air to enter and leave that system. Then the throat, which is an air and food passage, and the throat is also called the oral pharynx. Next is the epiglottis, which is the leaf-shaped structure. The epiglottis then covers the opening of the larynx when we swallow, which prevents food and fluid from entering that trachea. And then you have the larynx. So the larynx is the structure located at the top of the trachea, and it contains the vocal cords, also known as the voice box. So next we're going to talk about the lower airway. So in that lower airway you have the trachea. So the trachea is the air passage to the lungs, and it is located below the larynx, and it is sometimes called the windpipe. Next you have the bronchial tree. This is the structure that is formed by tubes that branch from the trachea. Its two main branches are the right and left main stem bronchi, one for each of the lungs. They branch into a secondary bronchi in the lobes of the lungs, and then the secondary bronchi then branch into still smaller bronchioles and eventually into the alveoli, which is that microscopic air sac where they have that exchange of gases, and that's where the exchange of gases takes place. Next, you'll have the lungs, which the lungs are that elastic organ that contains parts of the bronchi and the bronchioles, and as well as the alveoli, which then the alveoli are the small air sacs at the end of the bronchioles where the blood cells replenish that oxygen supply and then release any of their accumulated carbon dioxide. Here you will find all of the major components of the respiratory system. This is in your book, so I highly recommend reviewing all of these so you understand. Next, we'll talk about the respiratory cycle. So when the muscles responsible for breathing contract and enlarge the chest cavity, air flows through the mouth and nose into the throat, past the epiglottis, and into the trachea. Air then flows down and into the left and right main stem bronchi and through the smaller bronchioles to the clusters of alveoli. The alveoli are surrounded by tiny blood vessels called the capillaries, which is here where in the alveoli that the oxygen and carbon dioxide exchange takes place. Then oxygen travels through the walls of the alveoli and into the blood, which then delivers it to the cells. Carbon dioxide travels from the blood through the alveoli walls, where it is then eliminated when we exhale. So when working properly, the process of gas exchange is called respiration. I guess I got ahead of myself a little bit on that one, but the oxygen and carbon dioxide exchange takes place in the alveoli. The oxygen travels through the walls of the alveoli into the blood and then delivers it to the cells, where then carbon dioxide travels from the blood through the alveoli walls, where it is then eliminated and exhaled. So an open and clear airway is considered a patent airway. So before a breath can be taken, there must be an open and clear path into the lungs. This path is commonly called the airway and consists of passages that make up the nose, which is again the nasopharynx, the mouth, which is the oropharynx, the throat, which is also known as the pharynx, and then the trachea. So when an airway is open and clear, it is said to be patent. Assessing for and ensuring a patent airway will be one of the very first steps in the assessment of any patient that you would ever encounter. So in most situations, it will be obvious that the patient has a patent airway because he or she will be awake, sitting up, talking to people around them, to you, to family members, and so forth. It is when the patient is unresponsive that assessing the airway can become a bit more challenging. So an airway can become blocked by anything small enough to get caught in the airway. So some of the common causes of an airway obstruction include the patient's own tongue, secretions, vomit, foreign body of some sort, such as a piece of food or a small toy. It could be as much as swelling of the tissues that form around the airway. And so how to manage that airway? What do you do? So that, if you have an airway that has become blocked, it is discussed later in this chapter, by the way. But for now, just so you know, that without a patent airway, there's no way that the patient can breathe adequately. So you have to do something right away so that patient has or maintains that patent and open airway. In this section, we're going to talk about signs of normal breathing. As an emergency medical responder, you must carefully assess the breathing of every patient that you encounter. This will become one of the very first things that you look for and evaluate as you approach your patient. When observing somebody who is breathing normally, the process of breathing is almost invisible. But when the patient is in respiratory distress, the obvious sign is that there is an increase in effort that it takes to breathe, which is called the work of breathing, which then an increase in the amount of energy is necessary to breathe, which is called the increased work of breathing. So as you approach your patient, you must evaluate his or her breathing for the following characteristics. So the first thing that you're going to look for is you want to look for adequate tidal volume, which this is the amount of air that's being moved in and out of the lungs with each breath. The tidal volume can be assessed by observing even the effortless rise and fall of the chest with each breath. And then the normal tidal volume is present when the rise and fall of the chest is effortless and even. It's the exact same. And then the decreased tidal volume is likely when the chest rise and fall is shallow, rapid, or even irregular. Next, you want to listen for air entering and leaving the nose and the mouth. The sound should be quiet, like a soft breeze. There shouldn't be any gurgling, gasping, wheezing, or any other unusual sounds. Noisy breathing indicates some form of a partial airway obstruction. If the patient is unresponsive, you may need to place your ear and cheek next to his or her nose and mouth to feel and listen for air moving in and out. You may also observe the chest and abdomen or place a hand on either the lower chest or feel for chest rise and fall. You then also want to observe that skin color. Although every person's skin is different in color, the skin should not be pale or have signs of cyanosis, which is that tinted blue color. And then look for these signs, especially around the lips and the nail beds. That's where you're going to see that cyanosis first. And then you want to observe the patient's level of responsiveness. So a responsive patient who is not having difficulty breathing is almost always breathing normally. In this section, we're going to talk about signs of abnormal breathing. So signs of abnormal breathing. A patient who is unable to breathe normally is said to have difficulty breathing or be in respiratory distress. This is sometimes called shortness of breath, and the medical term for this is considered or called dyspnea. The following are common signs and symptoms of abnormal breathing. So the increased work of breathing, shallow or absent rise and fall of the chest, little or no air heard or felt at the nose or the mouth, and noisy breathing or gasping sounds. Breathing that is irregular, too rapid, or too slow, breathing that is too deep or labored, use of accessory muscles in the chest, abdomen, and around the neck, and the nostrils that flare when breathing. Skin that is pale or cyanotic, sitting or leaning forward in a tripod position, agonal respirations, which are the slow, sporadic gasps of air from the unresponsive patient. In this next section, we're going to talk about rescue breathing. Rescue breathing is the process of providing manual ventilations for a patient who is not breathing on his or her own or who is unable to breathe adequately. There are many terms for this process, including positive pressure ventilation and pulmonary resuscitation. Rescue breaths are indicated when a patient is unable to breathe with the adequate rate and volume to sustain life. Rescue breaths are not appropriate for a patient who is responsive or an unresponsive patient who is breathing with a normal rate and tidal volume. One type of rescue breathing is called mouth-to-mask breathing, which is during mouth-to-mask, you want to provide that air that is coming from your lungs to the patient. For this reason, you might wonder if you're providing enough oxygen. So the atmosphere contains about 21% oxygen. The air exhaled from the air that's exhaled from your lungs can contain up to 16% oxygen. And this is more than enough oxygen to keep most patients biologically alive until they can receive supplemental oxygen. In this section, we're going to talk about opening the airway. Opening the airway. Before a patient can breathe normally or before you can provide rescue breaths, the patient must have an open and clear airway. You must ensure that the nose, mouth, and back of the throat are clear of any obstructions. In a non-responsive patient, the tongue can relax and drop into the back of the throat, causing a partial or complete airway obstruction. This is referred to as the anatomical obstruction. The simple act of tilting the head and lifting the chin should correct this problem. If a responsive patient is showing signs of obstruction such as choking, the problem is likely to be an object stuck in the throat. You want to immediately begin the steps for choke saving. Next, you want to reposition the head. In an unresponsive patient, you want to simply reposition the head, which may be enough to open that airway. If the patient is lying on his or her back or in a supine position, you want to tilt the head back slightly by removing pillows or by repositioning the patient's head if it is not flexed forward. For infants and small children, you may place a flat pillow or folded towel beneath the shoulders to help maintain that head in a more neutral position. There are two common methods of opening the airway of a supine patient. The first is the head tilt chin lift maneuver, and this is used for patients with no suspected spine injury. And the second is the jaw thrust maneuver, which is used for patients that you suspect have an injury to the spine. To perform the head tilt chin lift maneuver, you want to place one hand on the patient's forehead and 2 fingers of your other hand on the bony part of the patient's chin. You want to gently tilt the head back while lifting the chin. You want to be careful not to compress the soft tissue under the jaw. You want to lift the patient's chin so the lower teeth are almost touching the upper teeth. This maneuver will lift the tongue away from the back of the throat and allow air to flow freely as the patient breathes. For patients with a suspected spine injury, use the head tilt chin lift maneuver only if the jaw thrust maneuver is unsuccessful. Here's an example of the head tilt chin lift maneuver to open that airway if you do not have a suspected spinal injury. The jaw thrust maneuver is the recommended method for opening the airway of patients with possible neck or spine injuries. You want to position yourself at the top of the patient's head. Reach forward and place the index and middle finger of each hand on either side at the angles of the jaw. You may press your thumbs against the cheekbones for leverage. Lift the jaw forward and do not tilt or rotate the patient's head. Either method can be used in conjunction with a pocket face mask when manual ventilations are required. Again, with that jaw thrust maneuver, you want to press your thumbs against the cheekbones, lift the jaw forward, and do not tilt or rotate the patient's head. Here's an example of the jaw thrust maneuver. In this section, we'll discuss barrier devices. All emergency medical responders should use a barrier device such as a pocket mask or face shields when providing rescue breaths. When you perform rescue breathing, you can come into direct contact with the patient's body fluids, such as respiratory secretions, saliva droplets, blood, or vomit. You want to take all steps necessary to ensure protection from the infectious disease. You always want to protect yourself. One example of a barrier device is the pocket face mask. The pocket face masks are available in many sizes and should fit the patient and seal easily to the facial contours of the adult, the child, or the infant. Pocket face masks are typically made of durable plastic and have a replaceable one-way valve and filter. Some variations have an oxygen inlet to allow for the administration of supplemental oxygen. Here's what a typical pocket face mask with the HEPA filter looks like. In this section, we're going to talk about mouth-to-mask ventilation. The mouth-to-mask technique of providing rescue breaths is the recommended method when there is only a single rescuer present. It is a quick setup and relatively easy to facilitate. A pocket mask allows you to provide ventilation without having to make direct skin-to-skin contact. The mask should have a one-way valve to minimize the chances of rescuers breathing in exhaled air from the patient. The pocket mask that you should use also comes with a disposable filter called a high-efficiency particulate air, which is the HEPA filter. It snaps inside the pocket face mask and traps air droplets and secretion that may contain dangerous pathogens. The pocket mask is made up of a soft plastic material that can be folded and carried in your pocket. It is available with or without oxygen inlet. If the mask has a second port for oxygen, you can simultaneously ventilate the patient with room air from your lungs and with additional oxygen from the oxygen source. Another advantage of the pocket mask is that it allows for you to use both your hands to maintain a proper head position and still hold the mask firmly in place. It is relatively easy to keep a good seal between the face mask and the patient's face with this device. The pocket mask can be used with or without an airway adjunct, either the oral or the nasal airway. To provide mouth-to-mask ventilations, make sure that you are wearing appropriate PPE. So first, you want to kneel by the bedside of the patient and confirm unresponsiveness. Next, you're going to open the airway using the most appropriate maneuver. Then you're going to firmly hold the mask in place while keeping the airway open. To accomplish this, you're going to place both the thumb and the index finger on the cone of the mask to form a C around both sides, and then apply even pressure on both sides of the mask. Next, you're going to take a normal breath and breathe slowly into the one-way valve, delivering each breath over 1 second. Air will then enter through the airway and through the patient's nose and mouth. You want to watch for the patient's chest rise. Remember that there is no need to remove your mouth to allow the patient to exhale. The patient's exhaled air will escape through the separate vents in the one-way valve. If the air does not enter on the initial breath, you're going to reposition the patient's head and try again. If it still does not enter, perform the steps for clearing an obstructed airway, which is going to be explained later on in this chapter. If the initial breath is successful but the patient does not begin breathing adequately on his or her own, assess the presence of a pulse and begin CPR if indicated. As an alternative method for ventilation with a pocket mask is to kneel at the top of the patient's head, place both thumbs and index finger on the cone of the mask to form a C around both sides. Place the third, fourth, and fifth fingers of each hand under the jaw to form an E on both sides of the patient's jaw. You want to then apply even pressure on both sides of the mask while maintaining that head tilt. The best indication that you are providing good ventilation is obvious chest rise and fall with each ventilation. If you find that your efforts to ventilate the patient are not adequate, you must make adjustments and start repositioning the head, increasing the volume, changing the rate of ventilation, or adjusting the seal between the mask and the patient's face. It is not unusual to see the patient's skin color improve with good ventilations. Here's an example of them providing ventilations with a pocket mask. In this section, we're going to talk about mouth-to-shield ventilation. With mouth-to-shield ventilation, you want to make sure that you are wearing the appropriate PPE and follow these steps. First, you want to confirm unresponsiveness and open the airway. Place a barrier over the mouth. Keep the airway open as you pinch the nose closed, and open your mouth wide and take a normal breath. As I said, you're going to take a normal breath and place your mouth over the face shield opening. Make a tight seal by pressing your lips against the shield. You're going to exhale slowly into the patient's mouth until you see chest rise. Break contact with face shield to allow the patient to exhale. Repeat the process for a second breath, and if the patient does not begin breathing adequately on his or her own, begin CPR. Some common problems that you may come in contact with is failure to form a tight seal, failure to pinch the nose closed, failure to tilt the head back to an open airway, or failure to open the patient's mouth wide enough to receive the ventilations. Failure to deliver enough air, providing breaths too quickly, or failure to clear the airway obstructions. Use your hand to seal the mouth shut, seal the mouth around the patient's nose, deliver the ventilations through the nose, break contact with the nose and open the mouth slightly to allow the patient to exhale, and keep your hand on the patient's forehead to keep an airway open. In this section, we're going to talk about special patients. So some special situations. So among your patients will be infants and children and older adult patients. The patients with the stoma, which is that surgical hole in the neck for breathing, trauma patients, and some with possible head, neck, and spine injuries. So infants and children. The airways of infants birth to 1 year and children 1 year to the onset of puberty have several physical characteristics that are different from adults, and in the infant and child, the mouth and nose are much smaller and more easily obstructed. The tongue takes up more space in the mouth and throat. And the trachea is smaller and more easily obstructed by swelling. It is also softer and more flexible and can become obstructed by tilting the head back too far, which is also known as hyperextension. The chest muscles are not always well developed, causing an infant and child to depend more on the diaphragm for breathing. And then the chest cavity and lung volumes are smaller, so gastric distension, which is the air getting into the stomach, occurs more commonly. The airway of an infant or child can be occluded easily if the head is allowed to become too flexed or too extended. An infant's head should be placed in a neutral position and a child's head in a slightly extended position. You must recognize and aggressively care for the airway and respiratory problems in infants and children. Respiratory distress can quickly lead to cardiac arrest in these patients. When assisting ventilations for an infant or a small child who has a pulse but is not breathing normally, make sure you take the appropriate BSI precautions. Then perform the following steps. You want to confirm the unresponsiveness, open the airway, use a barrier device, and assist ventilations with gentle but adequate breaths. Here's an example of a mouth-to-mask ventilation of an infant. Terminally ill patients. So there's many terminally ill patients who choose to spend their remaining time at home with family and friends. Hospice programs support the advice and advise the terminally ill patient and family members. Many patients who are under hospice care have written orders regarding what they want for their care, which may not include rescue breaths or compressions. So for guidelines on how to care for hospice or DNR patients, you want to check with your local protocols and jurisdiction for any training programs and follow your local protocols and what your medical director advises. Some people have had a surgical procedure called a laryngectomy or a tracheostomy. It then leaves an opening called a stoma, which is made from the outside of the neck to the trachea to create an airway for that patient to breathe. These patients breathe through that opening, not through the nose or the mouth. So because the patient primarily takes air into the lungs by the way of the stoma, you will have to use the mouth to mask to stoma technique to assist with the ventilations. Currently, there is no specific mask for the ventilation of these patients, but an infant mask often fits. It then allows you to establish a seal around that stoma. You may also assist ventilations with a protective face shield or by attaching a bag mask device directly to the patient's stoma tube if one is in place in the stoma opening. You then want to follow your protocols of your jurisdiction. If you don't see chest rise and fall when attempting to ventilate through the stoma, that's when you're going to cover the nose and mouth to block any escaping air during each rescue breath. So when ventilating a stoma, you want to take appropriate BSI precautions and perform the following steps. You want to keep that patient's head in a neutral or normal position and do not tilt that head. You then want to ensure that that stoma is free and clear of any obstructions such as mucus or vomit. And do not remove the breathing tube if one is actually in place. You want to use the same procedure as you would for the mouth to barrier resuscitation, except do not pinch the patient's nose closed. Place a mask or a face shield on the neck over that stoma. If the chest does not rise, the patient may be maybe a partial neck breather, which this means that the patient takes in and expels air through the mouth and the nose. So in such cases, you will have to then pinch the nose closed, seal the mouth with the palm of your hand, and ventilate that patient through the stoma. So this is a surgical stoma on the anterior part of the neck. With trauma patients, you want to open the airway and assist ventilations, which are easier for you to perform when the patient is lying supine. This means that a trauma patient who is not breathing but who is still in his or her vehicle must be repositioned. There's always a risk of causing further spine injury if you move that patient, but you have to be realistic. If you wait for other EMS personnel to arrive, or if you take the time to put on a rigid C-collar or secure that patient to the spine board, the patient will likely not survive due to the lack of oxygen of the brain. Airway and breathing are always the first priorities of patient care. Without risking your own safety, you want to take BSI precautions and reach the person as quickly as possible. You want to look, listen, and feel for breathing before moving him or her. If the patient is breathing, the airway is open, then you don't have to move him or her. If you believe that the mechanism of injury may have caused damage to the spine and neck, and you believe that the patient is not breathing, stabilize the head and attempt to open that airway with a jaw thrust maneuver. Then check again for breathing. If the patient is breathing, keep the airway open while maintaining the head and neck in a neutral position. You want to monitor breathing until assistance arrives. If the patient is not breathing on his or her own, then you're going to position them and allow you to maintain an open airway while you assist with the ventilations. You will have to reposition him or her at that point. In the next section, we're going to talk about air in the stomach and vomiting. A common problem with rescue breathing is air in the stomach. It can be caused by overinflating the lungs or delivering rescue breaths too quickly. Remember to carefully watch the chest rise as you ventilate. Provide only enough air to cause the chest to rise noticeably. Forcing more air in than the lungs can hold during the ventilation can cause or worsen the inflation of the stomach. Air in the stomach will cause the abdomen to be distended or get larger. This condition is called gastric distension. You want to watch for gastric distension when you ventilate a patient. Excessive gastric distension will reduce the ability of the lungs to expand normally. You want to reduce the lung capacity restrictions, ventilations, and limit oxygen flow to the body. Gastric distension can also cause extra pressure in the stomach, which can result in the patient vomiting. Do not worry about slight stomach bulging, but you will have to make adjustments if you notice excessive bulging. In cases of air in the stomach where you see a noticeable bulge, you want to reduce the force of your ventilation and do the following. 1, you're going to reposition the patient's head and ensure that the airway is open. Next, you're going to be prepared for vomiting. If the patient begins to vomit, you're going to turn them as their whole body, not just the head, to one side so the vomit will flow out of the airway and not back into it. Have suction equipment on hand if you carry it in your unit. And do not push on the stomach to release that air. This may cause vomiting, which can then block the airway and enter the lungs. Even if the patient is on his or her side when vomiting, the vomit will simply not flow back in. With the gloved hand, clear the patient's mouth with gauze and a finger sweep, and use suctioning equipment to get the remainder of the vomit out. In this section, we're going to talk about airway obstruction. The airway is divided into the upper and lower airways. The dividing line is the opening of the larynx or the vocal cords. The lower airway obstructions are difficult to manage and often require advanced training. You will be able to assess and manage most upper airway obstructions. Many factors can cause the airway to become partially or completely obstructed, including a foreign object that's lodged in the airway or excessive saliva or blood accumulating in the mouth. The following examples are of upper airway obstructions that you may be able to relieve. Obstruction of the tongue or the anatomical obstruction. This is one of the most common causes of airway obstruction in unresponsive patients and is caused when the base of the tongue falls back into the pharynx and blocks the airway. Next is foreign objects, which is considered a mechanical obstruction. The objects and other matter, such as pieces of food, ice, toys, dentures, vomit, and liquids pooling in the back of the throat, can block that airway. The next one is the following obstructions may be impossible for you to relieve, but you must still attempt to assist these with the ventilations. So the first one is tissue damage. Tissue damage can be caused by trauma to the neck, upper airway, burns from breathing superheated air from either a fire or an explosion, and poisonings. The tissues of the throat and windpipe become swollen and make it difficult for air to flow through that airway. Next is the allergic reaction. The tissues of the oropharynx, tongue, and or the epiglottis become swollen in the response of the patient's exposure to something that he or she is allergic to, such as a bee sting or certain foods. And next is infections. The tissue of the throat and the trachea can become infected and swollen and then can produce an airway obstruction. Signs of partial airway obstruction. A patient who is having difficulty breathing may have only a partial obstruction and may still be able to move some air. So the signs of a partial airway obstruction include the following. It could be noisy breathing, such as snoring, which is evidence of a partial obstruction usually caused by the tongue. Gurgling, which is usually caused by fluids or blood in the oropharynx and or the upper airway. Stridor, which is a high-pitched sound, typically on inspiration, which is caused by swelling of the larynx, and it's also referred to as crowing sound. So if you hear stridor or crowing, it's the same thing. Wheezing, which is a high-pitched whistle sound that's usually due to swelling or spasms of the lower airway, and it is more common during exhalation. So the increased work of breathing with the skin that is pale or blue at the lips or nail beds. Usually the presentation in a responsive patient is fear, panic, or even agitation. So very few things can invoke terror in a person, like threatening the airway or the inability to breathe. So if a responsive patient is experiencing a partial airway obstruction, you want to encourage him or her to keep coughing. So a forceful cough indicates that he or she has enough air exchange, and coughing may dislodge and expel those foreign materials. Do not interfere with the patient's own efforts to clear the airway if he or she is able to produce that repeated strong cough. But if the patient has poor air exchange and cannot cough or coughs only weak, then you want to begin care as if there was a complete airway obstruction. So the care for the complete airway obstruction will actually be discussed a little bit later in this chapter. Signs of complete airway obstruction. So when the airway is completely obstructed, the responsive patient will be unable to speak, breathe, or cough. The patient will often grasp his or her neck and open his or her mouth, which is the universal sign of choking. So the unresponsive patient will not have any of the typical chest movements or other signs of good air exchange. So here's a patient that is displaying the universal sign of choking. Again, there's no air movement and they're not coughing. So clearing a foreign body airway obstruction, when you're talking about a responsive adult or child patient, there is still ongoing research conducted by the AHA or the American Heart Association that suggests that the use of abdominal thrust is still the most effective method for clearing the airway of a responsive adult or child older than 1 year who is choking. A slightly different technique is used to clear the airway of an infant. So abdominal thrusts are achieved by having the rescuer stand behind the patient, place one fist just above the navel, grasp the fist with the other hand, and provide inward and upward thrusts. So these thrusts actually push up on the diaphragm muscle, creating pressure inside the chest cavity and forcing air out of the lungs. So as the air is forced out of the lungs, it then pushes the foreign airway, that foreign object, out ahead of it. So in the next few slides, we're going to show how to perform the following steps for removal of a foreign body airway obstruction for that responsive adult and child. So first, you want to confirm that there is a complete obstruction or a partial obstruction with poor air exchange. The easiest is to ask, are you choking or can you speak? You want to look and listen for signs of complete obstruction or poor air exchange and tell the patient that you will help them. So first, you're going to stand behind the patient, place one leg between the patient's legs to obtain a stable stance. Next, you're going to reach around with one hand to locate the patient's navel. Then with the other hand, make a fist and place it just above the patient's navel. Then you're going to grasp your fist with the first hand and pull in and up with swift, firm thrusts until either the object comes out and the patient starts breathing on their own, or until they go unresponsive. So with the unresponsive adult or child with an foreign body airway obstruction, you want to make sure that you are applying these next steps to adults and children from the age of 1 year and up. So when you suspect a patient may be suffering from an airway obstruction, you want to move swiftly to clear that airway. For any unresponsive patients, you want to act quickly to determine if you are able to provide adequate ventilations. Because the tongue is typically the most common cause of an airway obstruction for those patients, you want to make certain to open that airway using the most appropriate maneuver prior to attempting ventilation. Once you have confirmed that you are unable to ventilate, that's when you're going to begin CPR. So you're going to want to make sure you take that BSI precaution, and with the patient lying face up, tap and shout to assess the responsiveness, and if needed and if unresponsive, activate the 911 system. You're going to begin with CPR with chest compressions, and then after each set of 30 compressions, you're going to open the airway, check for any foreign objects, and then remove if visible. You're going to attempt 2 rescue breaths at that point, and if the breaths do not go in, continue CPR with chest compressions. For a responsive infant, the next steps for caring for an infant which is younger than 1 year of age are slightly different from those used for adults and children. So for the responsive infant, a combination of back blows and chest thrusts are used to remove that foreign object. So the first thing you're going to do is take appropriate BSI precautions. Pick up the infant and support between the forearms of both arms. And then rapidly deliver 5 back blows between the shoulder blades, turning the infant over and onto his or her back. You're then going to locate the compression site and deliver 5 chest thrusts with the tips of your fingers. And then continue the sequence of back slaps and chest thrusts until the object is expelled or the infant loses responsiveness. So just remember that back slaps are for clearing those foreign bodies in the responsive infants only, and do not use this procedure on adults or children. So here's the proper positioning of an infant for back blows. Here's the proper position for an infant for chest thrusts. When dealing with an unresponsive infant, you want to perform these next steps when caring for that infant who is unresponsive with a complete airway obstruction. So first, you're going to take appropriate BSI precautions. With the infant in a supine position, you're going to tap and shout to assess the responsiveness and then activate your 911 system. You're going to begin CPR with chest compressions. After each set of 30 compressions, you're going to open the airway and check for a foreign object. Remove it if it's visible with 2 fingers and make sure you're not doing a blind finger sweep. You're going to attempt 2 rescue breaths, and if the breaths do not go in, then you're going to continue with CPR. You're going to place the infant supine on a firm surface. If unable to detect signs of breathing, then you're going to start CPR, beginning with chest compressions. And remember, you're always checking the infant's pulse in the brachial artery. After 30 compressions, you're going to attempt 2 rescue breaths. Remember not to give too much air because your lungs are much larger than the infant. So as you can see here, place one hand on the chest, and when giving those breaths, as soon as that chest rises, then you have enough air in that infant. If you're unable to ventilate, you want to continue with 30 chest compressions. Some choking patients present specific challenges that must be overcome if you are going to have any chance of clearing that airway. For example, a patient's larger size may prevent you from getting your arms completely around him or her, making it impossible to provide adequate abdominal thrusts. Providing abdominal thrust to prevent a woman can cause serious injury to the developing fetus. For these 2 responsive patients, you want to attempt to provide chest thrust as an alternative to abdominal thrusts. For the obese patient, the chest area is typically smaller in diameter than the abdomen, making it more likely that you can provide adequate and successful thrusts. An alternative for the obese patient is to have him or her stand against a sturdy wall and attempt abdominal thrusts from the front. For the pregnant or obese patient, chest thrusts provide a suitable alternative and minimize the possibility of injuring the developing fetus. So first you want to determine if there is a complete or partial obstruction. While behind the patient, place one thumb of the fist on the center of the breastbone. Grasp the fist with the other hand and give up to 5 chest thrusts in a rapid succession. If the airway remains obstructed, repeat the thrusts until the airway is cleared or until the patient loses responsiveness. If the patient becomes unresponsive before you are unable to clear the airway obstruction, call 911 and begin CPR. On this slide is where you will see a pregnant patient. You're going to position yourself behind and then wrap your arms around the chest. Place the first of one hand flat against the sternum, grasp firmly with the other hand, and pull in sharply. A finger sweep is a technique of using your finger to sweep through the patient's mouth in an attempt to remove a foreign object. It is important to know that you should perform finger sweeps only if you can see the object in the patient's mouth. Be careful not to accidentally force the object back down the patient's throat in an attempt to sweep it out. In most cases, a responsive patient has a gag reflex. Probing the mouth with your finger may stimulate the gag reflex and cause vomiting. If this occurs, the patient may inhale the vomit, resulting in the potential for serious injury later. Therefore, attempt finger sweeps on only unresponsive patients and for only when you actually see the object that you are going after. It is best technique to grab the object out with 2 fingers rather than the blind finger sweep. In this section, we're going to talk about aids to airway management. The use of appropriate airway adjunct can help the emergency medical responder with more effective airway management. There are a variety of devices in the EMS system across the United States. Some of them are used by both EMTs and paramedics with more advanced training and are not within the scope of practice of the typical emergency medical responder training course. There are 2 common types of airway adjuncts commonly used by emergency medical responders. The first one is an oropharyngeal airway, or also known as an OPA. And the second one is a nasopharyngeal airway, or known as an NPA. As you learn to use these devices, it is important to understand that they are only adjuncts or aids that assist you in managing a patient's airway and breathing status. They do not guarantee an open airway. The OPA and NPA help the EMR maintain an open airway for the patient, allowing more effective ventilations to be delivered. With less risk of being exposed to the patient's body fluids, the bag valve mask device allows the emergency medical responder to deliver better ventilations for those patients who are not breathing adequately on their own. The OPA and NPA are often used together with the bag valve mask device to provide the best possible ventilations. One disadvantage of all adjunct equipment is that it can delay the beginning of resuscitation if it is not readily available. Your pocket mask and your airway adjunct should be always handy. Never delay the start of ventilation or CPR while you're trying to retrieve an airway adjunct. Oropharyngeal airways are broke down into sections. So oro refers to as the mouth. Pharyngeal refers to the throat. It's usually made of plastic, and the oropharyngeal airway, or the OPA, is a device that can be inserted into the patient's mouth. It has a flange that rests against the patient's lips. The lower portion curves back and into the throat and rests against the patient's tongue, restricting its movement and minimizing the chance that it will block the airway. Once a patient's airway is opened manually by using either the head tilt chin lift or the jaw thrust maneuver in trauma patients, an OPA may be inserted to help keep the tongue off the back of the throat. OPAs should be used only in unresponsive patients who do not have a gag reflex. These devices can stimulate a patient's normal gag reflex, causing him or her to vomit. If the unresponsive patient vomits, he or she can aspirate or breathe the vomit back into the airway and lungs, causing a blockage and possibly a serious infection. If the patient is responsive, even if they are disoriented or confused, or they are unresponsive with a gag reflex, do not insert an OPA. Do not continue to insert or leave the device in the patient's mouth if you meet any restriction or if the patient begins to gag as you insert it. Immediately remove the airway and prepare to suction if they do vomit. Next, you're going to attempt to insert an NPA. You may already see that the rules for deciding whether or not to use an OPA may seem contradictory. You are also not supposed to use an OPA on a patient with a gag reflex. Yet you will not know if the patient has one unless you attempt to insert that OPA first. To resolve this dilemma, you must be very focused as you insert the OPA in your patient. You want to expect that he or she may have a gag reflex, and at the first indication that he or she does, remove that device immediately. If you carry a suction unit and are trained to use it, have it ready for any patient who is unresponsive and may need an adjunct. You do not want to be caught unprepared and your patient in case your patient happens to vomit. Prior to placing an OPA, you want to open the mouth with the crossed finger technique. Here are various sizes of the oral pharyngeal airway. You need to properly measure the airway prior to insertion. Next, you're going to insert the airway with the tip pointing to the roof of the patient's mouth. When halfway in, you're going to rotate it 180 degrees. The flange should rest on the outside of the lips and never any farther than the teeth. An alternative method would be to go in at a 90-degree into position and insert the airway sideways and then rotate it 90 degrees. So another alternate method would be in a child is to insert an oral pharyngeal airway into the child using a tongue depressor. The nasopharyngeal airway, or the NPA, is a soft, flexible tube that is inserted into the nose to create a clear and open path for air. It is the preferred choice when the patient is not totally unresponsive or has a gag reflex. An NPA is easy to insert because you do not have to reposition the patient's head or pry open the mouth. If there is any injury to the mouth, teeth, or oral cavity, the NPA will still provide an open airway for the patient. There are numerous sizes of NPAs designed to fit infants, children, and adults. To use an NPA effectively, you must be able to select the correct size for that patient. The most widely used method for determining the correct size is to measure from the tip of the patient's nose to the tip of the earlobe. If the device is not the correct size, do not use it on that patient. Instead, select another one and remeasure to ensure the correct size before inserting. Note that some research studies have suggested most reliable method for sizing the NPA is by the patient's height. So first you're going to take BSI precautions. Select the appropriate size device by measuring from the tip of the patient's nose to the tip of his or her earlobe. You're going to use a water-based lubricant on the outside of the tube before you insert it. And then you're going to keep the patient's head in a neutral position while you gently push the tip of the nose upward. Insert the device straight back through the nostril. If the device has a beveled, angled end, then you should point that toward the septum or the midline of the nose. You're going to gently advance the device until the flange rests firmly against the patient's nostrils. Never try to force the device. If it will not advance into the nostril easily, you're going to remove it and try in the other nostril. If the device will not advance into the other nostril, make another attempt with an NPA that is slightly smaller in diameter. Here is various types and sizes of the nasopharyngeal airways, or the NPAs. You want to select the appropriate sized airway for your patient. Next, apply a water-based lubricant before inserting it into the patient's nostril. Gently insert the airway, advancing it until the flange rests against the nostril. And then the nasopharyngeal airway is properly inserted. In this next section, we're going to talk about bag mask ventilation. The bag mask device is one of the most commonly used devices for ventilating a non-breathing patient. Some EMS systems also use the bag mask device to ventilate patients with inadequate respirations, such as with a drug overdose. The bag mask device is available in sizes for infants, children, and adults. It also acts as an effective infection control barrier between you and your patient. The bag mask device delivers room air at 21% oxygen to the patient when it is squeezed through the unit to the patient's lungs. In contrast, a pocket face mask will deliver up to 16% oxygen from your exhaled air. The bag mask device can be connected to an oxygen supply source to enrich room air and deliver concentration of up to 100% oxygen. There are many brands of bag mask device available, but all have the same basic parts: a self-filling bag, a one-way valve, and a face mask. All bag mask devices have a standard fitting that makes them compatible with the most respiratory equipment and face masks. Most bag mask devices used in the field are disposable and intended for single patient use. The principle behind the operation of the bag mask device is simple. When you squeeze the bag, the air is delivered to the patient through a one-way valve. When you release the bag, fresh air enters the bag from the rear while the exhaled air from the patient flows out near the mask. The exhaled air does not go back into the bag. There are times when the bag mask device will not deliver air to the patient's lungs. Sometimes the problem occurs because the patient has an airway obstruction that must be cleared. More often, the problem is caused by an improper seal between the patient's face mask, and if this occurs, you should make sure you reposition your fingers and check the placement of the mask. Here is a variety of bag mask devices in several different sizes. For the best possible results, the bag mask device should be used with 2 rescuers. Prior to using the bag mask device, you want to insert an appropriate airway adjunct. One rescuer must use 2 hands to maintain a good mask seal, while the second rescuer squeezes the bag. Note that for trauma patients who must have their airway opened by the draw thrust maneuver, the 2 rescuer method is more effective. The rescuer holding the mask in place can more easily perform the jaw thrust, while the other rescuer provides effective ventilation. Here is the proper technique for using the bag mask device with 2 rescuers. Here is the proper hand position for the bag mask device with 2 rescuers. For a single rescuer alone, the bag mask device can be difficult and challenging to operate. The bag mask device is not the recommended method for a single rescuer. This is especially true if you have small hands or do not use a bag mask device on a regular basis. The most difficult part is maintaining an adequate mask to face seal with one hand. If you are assigned to a bag mask device for use in the field, practice using it in the classroom until your technique is well developed. Here is the suggested technique for using the bag mask device with a 1 rescuer. This is an alternative method. You can actually press the bag against your leg. In this next section, we're going to talk about suction devices. It is quite common for an ill or injured patient to experience nausea in response to his or her condition. Sometimes this nausea can lead to vomiting, putting the airway at risk for obstruction. Other times, trauma to the head, face, or mouth can lead to bleeding inside the nose, mouth, and airway. One of the simplest methods for clearing the blood, mucus, and other body fluids from the patient's airway is to position the patient on his or her side, which is also called the recovery position. You're then going to use finger sweeps appropriately. In addition to this manual method, the use of mechanical suction devices can be very helpful in clearing the fluids. There are several types of portable suction devices available, including manual-powered, oxygen, or air-powered, and electrically powered units. All types of suction units must have specialized non-collapsible tubing, a collection container, and an appropriate suction tip or catheter for inserting into the patient's mouth or nose. Catheters are available in a soft, flexible tube for suctioning the nose and a rigid plastic for suctioning the mouth. Here's an oxygen-powered suction device. This is typically what most rescue squads carry, which is the manually operated suction device, or also called a VVAC. Here is your battery-powered suction unit. And in most transporting ambulance services, they have a suction unit that is installed in the patient compartment of the ambulance. With the suction devices, they are thick-walled, non-kinking, wide-bore tubing. It is with an unbreakable collection container, which is sterile, disposable, semi-rigid, but flexible or rigid suction tips. You always want to be sure to use appropriate BSI precautions, including mouth and eye shields. The potential for being sprayed with body fluids such as vomit, blood, and saliva can be high. Keep your suctioning time to a minimum. Remember that while you are suctioning, you are not ventilating. One suggested guideline is to suction for no more than 15 seconds for the adults, 10 for children, and 5 seconds for infants. If there is copious amounts of fluid in the patient's airway, it may be helpful to roll him or her on their side and then suction. You may need to suction, ventilate, and suction again in a continuous sequence as long as necessary. You want to measure the suction catheter prior to insertion. Activate the suction unit only after it is completely inserted and as you withdraw the catheter. Twist and turn the tip of the catheter as you remove it to minimize the chance it will become stuck on the soft tissue lining of the mouth and nose. When suctioning the mouth, concentrate on the back corners of the mouth where the most fluid tend to accumulate. Do not place the tip directly over the back of the tongue because this will likely stimulate the gag reflex. Check the function of the suction unit prior to using it. For oral suction, insert the tip of the device only as far as you can see, and then initiate suctioning. In this next section, we'll do a quick summary. Respiratory compromise can be caused by asthma, bronchitis, drowning, and choking. Patent airway is clear, open, allows for effortless airflow. Clinical death occurs the moment that both breathing and the heartbeat stop. Biological death occurs for about 4 to 6 minutes following the clinical death. Signs of inadequate breathing is increased work of breathing, shallow, rapid, noisy, or gasping breathing. Provide rescue breaths using appropriate barrier device and use firm seal with the mask. Cause of airway obstructions can be the patient's own tongue, blood, saliva, and foreign objects. The preferred method of opening the airway of a responsive patient is abdominal and/or chest thrusts. Preferred method for opening the airway of a non-responsive patient who is uninjured is head tilt chin lift maneuver. The preferred method for unresponsive patient with suspected neck or spine injury is the jaw thrust maneuver. If you are unable to open the airway using the jaw thrust, attempt the head tilt chin lift maneuver. Unresponsive patients with no gag reflex should receive an OPA. For patients with a gag reflex, somewhat responsive, the NPA is the best choice as long as there is no trauma to the patient's face. When the patient is not breathing adequately or not at all, provide positive pressure ventilations or rescue breaths. The best sign that you are providing good rescue breaths is good chest rise and fall with each breath. To minimize flow of air into the stomach during the rescue breaths, provide slow, even breaths and do not overinflate the chest. If the patient's airway becomes obstructed with fluid, saliva, blood, or vomit, it will be necessary to suction the mouth and/or nose to remove the fluid and clear the airway.